Hello and welcome to your online lecture for drugs that are going to be used to treat infections. I'm Dr. Cosby. Today we're going to be talking about kind of microorganisms that are responsible for causing either local or systemic infections within the body. And so by microorganisms, what I'm really referring to for the most part are going to be bacterial infections, but I'm also going to talk through viral infection and fungi infections as well. So let's go ahead and get started. When you think about the world of athletic training and kind of all that this program is preparing me for, ultimately what we start thinking about is how do we prevent, how do we evaluate, and how do we treat basically athletic injury, right? And I would say 80% of what you're going to do when you leave our program, right? And then kind of go into the field of athletic training will be that prevention, evaluation, treatment of development of rehab programs. But then alarmingly enough, the second type of pathology that will present to you will be illness. And so part of the role of the program, if you're sitting here wondering like, why am I taking an 8-week pharmacology class? Well, this is the reason why, right? You're going to have patients who walk into the clinical setting and aren't feeling well, who have a fever, who have body aches, who have chills. And so part of the role of this program is to also help you identify to equip you with the skills to identify the different types of illnesses, maybe even to dive a little bit deeper and to help you differentiate between a bacterial infection and a viral infection. But for the sole purpose of this class, we're going to be talking through the different types of drugs or medications that your patient may be on. And so it won't be important to really understand the dosing of that medication because obviously you really won't be able to administer that because most of the medications, with the exception of maybe topical medications, are going to be prescription based. But it becomes important to understand that after injury, the second most common type of kind of pathology or disease that you're going to see is going to be illness. So that's why you're taking this pharmacology class. If you keep wondering that every week, I'll keep reminding you. The great thing about illnesses is that they're going to range, right? One end of the spectrum would be not systemic and not life-threatening, right? Something like ringworm, something like jock itch, for example, maybe even the common cold. The other end of the spectrum is life-threatening, right? You can have a patient who has COVID-19 symptoms that maybe aren't treated and they pass away. We were living in a pandemic and now we have this thing called COVID-19, which we soon learned was very life-threatening. Many people lost their life in the pandemic, right? Or became really ill and now have long-term signs and symptoms as a result. So we can see that illnesses caused by microorganisms can certainly have a very small short-acting impact or can have a large detrimental impact. And so for you all, it becomes important to figure out how to treat these illnesses well, right? Just as much as it becomes important to figure out how to treat injuries when our patients walk into the clinical setting, right? The hard part with illnesses that are caused by microorganisms is most often there's going to be some form of pharmacologic treatment that is required. And so that's why we're doing a whole lecture on microorganisms and the types of drugs that will be used to treat them. I think what I'm going to do is break this lecture down into two separate online lectures. The first one will really be focused in on bacterial infections. Those are probably the most common types of infections that you'll see. It's the type of infection that most often will be where physicians will prescribe drugs. And so we'll spend a bulk of the time talking about bacterial infections and bacterial drugs. And then the second online lecture that we'll have in this particular series will then be on viral and then fungal infections. I think that's the best way to do that. So your immune system, as you all know, is a natural system which usually is capable of attacking, destroying most microorganisms that might enter into our system, right? It's a pretty resilient system. Very thankful for that. Even when we get the common cold, it works to fight off the virus that's in our body. We'll destroy it, but we might have signs and symptoms, right? Common signs and symptoms of a viral infection, most often maybe some chills, maybe slight fever. That usually goes away within 2 to 3 days, right? But then there are times where our immune system gets attacked and it isn't capable of naturally fighting off that infection. And so that's where the pharmacological treatment will come in because it will either assist the immune system in attacking that microorganism or it's going to just completely destroy the microorganism that has entered into the body. So we know for the most part, unless we are immunocompromised, and we do have patients in this world who are immunocompromised. We have patients who maybe were born with leukemia, for example, and are constantly on like a low grade kind of chemo drug. And so their immune system is already compromised, right? We have patients who have cancer, obviously, and then also are going through chemotherapy. So those are two examples of ways in which patients can have an immunocompromised system. But for the most part, God creates us in such a way that our immune system is capable of fighting off most of the microorganisms that we're exposed to on a daily basis. And I don't know about you, but that just makes me more thankful for the way that I'm created, and for our maker who creates us this way to have this natural system that's capable of fighting off most of the microorganisms that we come into contact with on a daily basis. But there are times where we're exposed to pathogens or microorganisms that our immune system may not be capable of fighting by itself, right? Let's just take the news in the last 2.5 years. COVID-19 was a complete shock to many of us, right? And our immune system just could not fight off this virus, right? And for the most part, viruses, at least, our immune system is capable of fighting off. But in this particular case, because of the way that the virus mutated, our immune system could not fight it off as effectively as it normally could. And so we had to take different types of medications potentially to help the immune system fight off that particular virus. So there's going to be times where our immune system can't fight off a bacteria or a virus or a fungus, and that's where our pharmacological treatment will actually come in, right? It's going to assist the immune system or completely just destroy it without assisting the immune system, right? So let's dive deeper. There are different types of microorganisms. The three that we're going to talk about in this particular class are going to be bacteria, fungi, and virus. Bacterial infections are by far the most common that are treated pharmacologically. And then secondarily to that would be your fungal infections. And we'll talk through the different types of fungal infections that will be important for you to know as an athletic trainer. Viruses, for the most part, minus maybe COVID-19 or HIV, for example, for the most part, our immune system is capable of fighting off most viruses. So we won't spend a whole bunch of time talking about antiviral medications because, again, our resilient immune system is just capable of fighting them off. Let's talk about bacteria first because that's the most common type of systemic infection that we're going to kind of encounter as athletic trainers. One of the two key things I think to consider that make bacteria different than the human cell. The first one, probably the one that we try to treat the most often with pharmacological treatment, is that they have this kind of hard, rigid outer cell wall. And that hard, rigid outer cell wall, when you compare it to the human soft, pliable cell wall, makes it very difficult for the immune system to penetrate, right? To actually get inside it and to destroy the actual bacteria itself. So it has kind of this hard, rigid shell wall, and it's also a single cell microorganism. And it is this difference, really the hard cell wall, it is that difference that requires us to orally ingest some type of antibiotic in order to assist the immune system to kind of poke away or to eat at that cell wall, because our immune system just isn't capable of doing that on its own, right? So that distinct difference is the reason that we have to treat it pharmacologically. And so we're going to talk about the different types of drugs that will destroy pathogens that enter into the body. And those drugs as a whole are called antimicrobial. So anti meaning to destroy something, microbe meaning which type of microorganism are we dealing with. So we can have bacteria, fungi, and then virus, right? So we can have antibiotics, we can have antiviral drugs, we can have antifungal drugs, right? So that's what I'm referring to when I say something that's antimicrobial. It's something that's going to destroy a microorganism, right? But it doesn't have to be in the form of an oral medication. One of the things that I think about most often is during the pandemic, what's the one thing that became way overused? Probably anybody's hands get like really dry from using what? You got it, right? Hand sanitizer. Hand sanitizer is an antimicrobial. It's really an antiviral kind of topical kind of intervention, right? So we can see that antimicrobial doesn't always have to be oral. You can have soap that is antimicrobial, right? As an example, your pump soap, most of them are antimicrobial. The goal is to kill any of the pathogens sitting on the external surface before it actually enters into our internal environment. So we think about bacteria. One of the things that we have to really consider is that the body is equipped with these kind of natural substances. First of all, I already said, right, we have the immune system, which is natural, which is capable of attacking a lot of um, the the microorganisms that might enter into our body. And then additionally, we have in the body, we have good bacteria, and then we also have bacteria that is capable of causing systemic infection, and can be responsible for death, right? So we have to kind of weigh, there's this teeter-totter. We have good bacteria, we have bad bacteria. When we take an antibiotic, oftentimes it doesn't discriminate between the two. And that's where antibiotic therapy is can be extremely difficult or can cause adverse side effects, because what we know about good bacteria is that most of that good bacteria is going to live in our GI system, right? We call the good bacteria your gastrointestinal flora. So it's going to line the GI tract, kind of prevent like a lot of the ulcers. So it will also kill off naturally some of the bad bacteria. So we have good bacteria and we have bad bacteria. And what the goal of antibiotic treatment really is to destroy all of the bad bacteria while trying to maintain the natural bacteria that we need in the body to coat our gastrointestinal tract. So we have to keep that in mind. Now, we said, number one, bacteria has a hard outer wall. It's a single cell unit. The other thing about bacteria that differs between a human cell is that it lacks the process of mitosis or meiosis. So in other words, it lacks the ability to kind of separate, right? And so one of the things that it has to do is it has to utilize some of the body's energy to create that process, to replicate over time, which is why we see lots of crazy signs and symptoms with bacterial infections, right? So it's going to require nutrients, and it's going to steal those nutrients from you. And so what that means essentially is that there's less of those nutrients available for the natural cells circulating in your body. So you have the immune system struggling because you have less nutrients for it to survive and thrive. And you have these selfish bacteria, which can't thrive on their own, which need energy from you or from the cells in your body, right? So they either start to steal from the cells in your body, or they attach to the cells in your body, and then they start to replicate and produce more of themselves, right? So we have a very selfish bacteria because it can't thrive on its own. It has to steal from the body. So keep that in mind with bacterial infections. So we have these medications called antibiotic medications, and I'm going to guess that many of you probably at some point in time have used some type of either oral or topical or injectable antibiotic. The role of antibiotics is to kill bacteria. Again, going back to this teeter-totter where we have the good bacteria, which we want, which is going to coat and protect our GI tract. And we have the bad bacteria, which we want to destroy. And that's the purpose of these antibiotic medications, right? So let's talk through the different types of antibiotic medications that kind of are on the system. And before we can do that, before we can actually talk about the types, we have to understand, like, in general, what are the groups of antibiotics that are available. So we have to think about where they fall on the spectrum. And there are two different types of antibiotic medications most often. The first is going to be what we call is a narrow spectrum antibiotic. As the name implies, it very narrowly focuses in on a specific type of bacteria, right? So it's effective against a very small number of bacterial organisms or microorganisms in this case. So this drug, if we know the type of bacterial infection the patient has, this is the type of drug we want to use because it's specifically going to attack that bad bacteria. It will not attack our good bacteria, right? But that's given that we actually know what type of bacterial infection the patient has, right? If we know, then we use a narrow spectrum drug and it will really focus in on that bad bacteria, secondarily not destroying our good bacteria, right? And so we have less adverse side effects with our narrow spectrum bacterial drugs. On the opposite end of that, oftentimes, if a patient has a bacterial infection and the signs and symptoms are just so intense, sometimes we don't have time to figure out what bacteria is actually causing the signs and symptoms, right? So in that case, we use something called a broad spectrum bacterial drug, right? As the name implies, it's broad. So what it's going to do is it's going to be effective against a larger number of microorganisms or a larger number of bacteria because we just don't know. So we give patients a broad spectrum antibiotic, not knowing which bacterial infection they actually have. And this is good if we don't know, if it's the guessing game. The negative part of that, of course, is with broad spectrum antibiotics is because it's not really focused in on a specific type of bacteria. It's going to kill both the good and the bad, and there are deleterious effects for that, right? So we could see like maybe some stomach pathology going on, increased risk for ulcers, for example. But sometimes we have to use that broad spectrum antibiotic until we get, like, let's say, the results back from the swab in your mouth. So that's something to consider. Two types: narrow, broad. Narrow if we know we want to use a specific type of antibiotic. Broad if we don't know what's causing it, we'll just give them a broad one and it will kill everything, right? And so more adverse side effects associated with a broad spectrum antibiotic. Now, the type of drug can also have two different effects. The first is it can have a bactericidal effect or a bacteriostatic effect. Bactericidal drugs completely kill the bacteria, and this can be a good thing or a negative thing, and I'm going to talk through that in a second. Bacteriostatic drugs, on the other hand, slow down the rate at which the drugs can grow. So let's talk through bactericidal first. They completely kill off the bacteria. That's great. It destroys it right away, and it gets excreted through the body, and our signs and symptoms reduce quicker, faster, sooner. The problem with the bactericidal drug, as you all might be thinking right now, is it doesn't allow the natural immune system to fight alongside, right? And so that passive immune system becomes way more passive. And the next time we have an invading microorganism, it won't know how to defend. It won't know how to fight off that invading microorganism because that bactericidal drug does it all for the immune system. So we have a passive immune system becoming even more passive, right? So that's not a good thing because it doesn't identify the microorganism the next time it invades. Your bacteriostatic drug, on the other hand, the patient may have the symptoms and the signs for a little bit longer, but because it's only slowing down the rate at which the bacteria grows, it allows the immune system to naturally come in and destroy the bacteria that is in the environment, right? What that does is it allows the immune system to know the next time that invading organism attacks. It allows that passive immune system to become a little bit more active. It allows it to identify it and to destroy it. So you have to ask yourself, really the physician, not y'all, but you're going to have to ask yourself, like, is the goal to reduce the symptoms right away? Then you go bactericidal. We don't have time to wait. This patient is life or death, right? We're going bactericidal. If we have time in younger patients, those with thriving immune systems, then we go bacteriostatic, right? Because we want the immune system to be active, to be engaged so that it can identify the next time around. We have an immunocompromised patient. Which one do we want to use? Which one would you all use? Good. Hopefully you said bactericidal because we know that they're immunocompromised. We know that the immune system probably doesn't have enough go in it to fight off this infection. So we want to do it for them. So you have, when you think about antibiotics, we have to consider, okay, what kind of spectrum antibiotic are they on? Are they on a narrow or in the broad? Broad, they might have more adverse side effects. And then what type of antibiotic are they taking? Is it bactericidal, meaning immune system is very passive? So the next time they have an invasion with this particular microorganism, they might have more signs and symptoms. Or is it a bacteriostatic where the immune system is actively engaging, which means, honestly, when the immune system is actively engaging, the patient might be more fatigued because the systems are working overtime. So that's the first thing to consider with antibiotics. The second thing to consider with antibiotics, at least this is what a physician or a nurse practitioner, maybe a physician assistant might consider, is there are really three different types of criteria for figuring out what type of drug to prescribe. The first is we swab the patient and we put that under a microscope, right? And that allows us to identify the organism. The organism is either going to be gram positive, which means they're retaining the dye, or it's going to be gram negative, which means they do not retain the dye. And all of this is nothing that we do on our end. This is, okay, let's say we have strep throat, right? If you've had it done before where they'll do a rapid strep test in the office, right? And if it comes back positive, it's gram positive, they're going to prescribe a kind of a antibiotic that would help destroy gram positive bacteria. And if it comes back negative, right? So let's say it's gram negative, there's no retaining of the dye, they'll prescribe maybe an antibiotic that would help destroy a gram negative. So this helps the physician or the healthcare practitioner decide what type of antibiotic drug they're actually going to prescribe to that particular patient. Next, we have to determine the drug's sensitivity. So how effective is it at fighting off the particular bacteria in the system? And then in terms of resistance, like how apt is the patient, what's the right way to say this? How likely is it that the patient might become resistant to that particular type of medication? Those are all things to consider. And we'll find that some medications have more susceptibility to patients becoming resistant to it and others do not, okay? Last but not least is the patient, him or herself. Do they have impaired immune systems, first and foremost, right? Probably want to prescribe maybe a bactericidal drug for that particular patient. And then last but not least, we have to consider the blood-brain barrier and the vascularity of the actual anatomical structure that we're actually trying to treat, because we know the blood-brain barrier is very difficult to pass through. So we're going to have to find a very lipophilic drug, right? One that can penetrate that blood-brain barrier pathway and get to the target site, particularly the brain. That's the one that's going to be most protected by that blood-brain barrier. So we have these three different things that we have to consider, right? If we go back a slide, then we have these three kinds of types of antibiotics or typing of antibiotics. And now what we're really getting ready to do is talk about drug resistance. So what is drug resistance? Drug resistance is probably highest in antibiotic medications. So as we think about drug resistance, it's how does the patient become resistant to an antibiotic that they're taking? In other words, the antibiotic no longer is effective, right? So let's talk about that a little bit. You understand this from our pharmacokinetics and pharmacodynamics lectures, hopefully, if I did a good job. So this should kind of be a little bit of a review, but let's talk about it. So let's start over here first. One thing we have to consider about antibiotics is particularly bactericidal antibiotics will eliminate all of the susceptible bacterial strains, right? Now, one of the things that happens, remember, in that broad spectrum antibiotic is it's going to kill off the good and the bad, right? Because it cannot discriminate between the two. And so that kind of decreases the number of susceptible bacteria. That's great. But what it also does is it allows the resistant strains to kind of flourish a little bit, since there isn't any competition for nutrients, right? Because the good bacteria are gone. So those bad bacteria can just take all of the nutrients that they need. And so they're able to mitose, right? They're able to divide and split and then thrive and grow. And so that creates resistance in the patient. So you have these antibiotics, mainly broad. They eliminate all strains of bacteria. And so you have some free-floating bad bacteria, which are now able to take the nutrients that they need, continue to divide. And so then you just become resistant because there's so many different strains of bacteria that drug you're taking no longer is effective. So you have to change the drug that you're actually taking. The other ways that it can occur is the bacteria itself, the one that's actually in the environment, as it's able to take nutrients from different places, it can have a change in its genetic makeup. Does that make sense? So when it entered into the body, it looked and was shaped a certain way. And then as it started to mitose, it changed its shape, which means that your antibiotic that you once were taking may not work either more, right? And so that can happen. The change in genetic makeup can happen either by spontaneous random mutation, which can happen, right? In science, that can happen. Or if the antibiotic attaches itself and it starts to change the good bacteria into bad bacteria, either way that you think about it, right? And this can happen over here by connecting directly to a bacteria that's in the body, or just through DNA, right? And so there's this way scientific process. The moral of the story is that you can have a change in genetic makeup, you can have random mutation, any change in genetic makeup, any random mutation, any destroying of good bacteria allows for those bad bacteria to take more nutrients and to divide. And you have a process where the body can no longer, or the antibiotic can no longer recognize that actual bacterial strain that we originally prescribed it for. And so we get resistance. And so that's where you start to see physicians changing the types of antibiotic drugs, or it's why you see that antibiotics only prescribed for about 7 to 10 days. They haven't been effective for 7 to 10 days, then guess what they do? They switch it out. The goal is, if we could describe the optimal antibiotic, it would be a narrow spectrum bacterial static drug, right? One that's really focused in on that specific bacteria, but allows the immune system to come along. However, sometimes if the signs and symptoms are so great, we have to give a broad spectrum bactericidal drug, so it can just kill it all, kill everything right away, right? So you have to weigh those, the physician really has to weigh those processes as they're prescribing. So let's talk about why we would use an antibiotic. It's going to be, so any type of antimicrobial drug, let's put it that way, is going to be prescribed based on the type of microorganism, right? So we're going to do a swab and you take that out. That's going to confirm bacterial, viral, fungal. Then more specifically with bacterial drugs, we kind of have to know if it's gram negative or gram positive, right? That will help us decide whether or not we're prescribing bactericidal or bacterial static drugs, right? We also have to consider the site of infection. Is it the brain, where we have the blood-brain barrier, and we have to consider that process too? Is it just systemically and we just need to give a broad spectrum drug? And the type of the patient, right? Whether they're a child, whether they're immunocompromised, whether they're elderly, right? All of those things are going to play an important part in prescribing antibiotic medications. And then one other thing to consider, remember on that tree slide, right? We talked a lot about narrow versus broad, and narrow versus broad is extremely important. So as we think through these last two bullet points, something to consider, okay, which antibiotic is most likely going to be effective, right? Do we know the actual bacteria that has invaded the body? Then that's narrow all the way, right? Do we not know, but the patient has so many symptoms and we're concerned about life or death? That's going to be broad, right? That's going to take away everything and we'll have no concerns, right? What we know about narrow and broad, and I think I've said this so much that hopefully I'm nailing it into your brains. If I were in class, I'd be like, you guys, you tracking with me? Are you tracking with me right here? Here's the key thing. Narrow spectrum drugs, narrow spectrum antibiotics are the best type of antibiotic to prescribe. Number one, what we know is it attacks a very specific microorganism. So we have less side effects associated with that, right? The other thing that we see is that when we can really narrow it down to one specific antibiotic, there's a less development of antibiotic resistance, right? Because we're not destroying both good and bad. And so we have some good bacteria that are able to kind of keep fighting off in the immune system for us, right? But when we use a broad spectrum drug, because it just destroys everything, remember, there's still a little bit of the bad bacteria that can start taking nutrients and start mutating and start changing its shape, right? So our body doesn't recognize it. And so we develop an antibiotic resistance. So the ideal would be, the true ideal would be a narrow antibiotic bacterial static drug, one in which we specify a specific bacteria and we allow the immune system to come alongside that antibiotic and work together in parallel processes, right? That would be the ideal, but it just doesn't always happen that way, you guys. So I just want to make that kind of very clear for you all that prescribing drugs, I wouldn't want to be a physician. It's a very hard thing to do. So now we're going to go into the different types of drugs, classes of drugs, groups of drugs, however you want to say that. The first and most common type in prescribed antibiotic is going to be your penicillins. That's what we'll call them. They, if we think about their kind of pharmacokinetics, essentially, and their pharmacodynamics, what we're thinking about is how do they actually work in the body, right? That's what I would want to know. So the way that these drugs work is they inhibit the synthesis of the actual wall itself, the cell wall, right? That hard wall that prevents the natural immune system from destroying it, right? So they do that by kind of attaching to an enzyme that's responsible for kind of triggering the construction of the actual cell wall itself, right? So if the cell wall can't be built, then we know that the drug can then start to attach and start to destroy the actual bacteria itself. So this is most of the penicillin group, they're bactericidal in nature. The immune system will not have enough time to react, right? And that's okay. We want to just destroy the bacteria and in hopes that the signs and symptoms will reduce relatively quick and rapidly. Now, the penicillin group in general has what we call is a beta-lactam ring, and you can see that over here. And this is essential to penicillin's ability to fight off bacteria once we take that orally. The biggest concern with the penicillins is that bacteria in general, when a bacteria enters into the body, it will produce its own enzymes, right? That's kind of how it lives and it thrives. These enzymes are called the penicillinases. The penicillinases, guess what their major job is? Anyone want to tell me? To destroy the penicillin, right? So it's going to start degrading the penicillin so it can't have an effect, so it can't destroy the bacteria. That's kind of how bacteria morph. It's kind of how they mitose, is they release this penicillinase or enzyme into the system once they're allowed to attach, and that enzyme can destroy the drugs that your patient they're taking. So we're going to talk about that on the next slide so you can see which drugs might be resistant to the penicillinase. In other words, can fight off the penicillinase and get to the target site and have an effect, and which drugs are going to be sensitive to it. In other words, which drugs can be destroyed by the penicillinases and not have an effect. That will be important as well, right? We also know that most penicillin drugs are gram-positive. So in other words, they respond well to gram-positive strains. So what that means is we swab. If a patient has a gram-positive test, this might actually be a drug that we would want the patients to actually take. So let's take a look at this table here. One thing to note with the penicillin group, and the reason it's so heavily prescribed, is because it has a high therapeutic index. And if you recall from a previous lecture where we talked about therapeutic index, the higher the therapeutic index, the reduced risk for adverse side effects. So this is a drug that a lot of physicians will prescribe because patients typically don't have a whole bunch of adverse side effects. The two most common adverse side effects associated with any type of antibiotic therapy are going to be diarrhea and the development of rash. No one has ever died from either of those, unless of course maybe they get dehydrated, right? Most often your penicillin group is going to be used to treat mostly ear infections. They're going to be used to treat upper respiratory tract infections. The UTI would be urinary tract infections, and then heart infections as well. So we can see why it's more heavily prescribed. These are common things that we see oftentimes. And then also because it has that high therapeutic index, we're not really concerned that the patient is going to develop any really high, adverse side effects, right? So let's talk spectrum first, right? We have some penicillin drugs that are going to be more broad in nature. You can see those here. They're going to be all of the A antibiotics is what I call them, the amoxicillins or the ampicillins. So you can see that there. Then you have some that are going to be more narrow in nature. And that's where you kind of get into the original penicillin, the drug that was actually originally created, or the first drug that was approved on the market to treat infections or bacterial infections in particular. So we have the spectrum, which is is huge, right? Then we have something called the penicillinase, right? That is the enzyme that's produced by bacterial. The goal is to kind of destroy the drug as we orally ingest it. And so we have drugs that are going to be sensitive to the penicillinase, and then those that are going to be resistant. Those that are resistant are better, right? Because it means that they don't break down when the enzyme attaches to it. And so then they're able to be delivered to the target site. Those that are more sensitive, however, they get destroyed. And so we see less of effect of that particular drug. So in your broad spectrum drugs, there are two that are probably better to be prescribed because they're going to be penicillinase resistant, which means they're going to be able to travel to the target site and exert their effect, right? And so that's going to be amoxicillin plus, and then you have ampicillin plus, right? Okay. As we move to the more narrow spectrum drugs, you can see that the narrow spectrum drugs are way more resistant. In fact, all four of them are resistant to penicillinase, right? So where you can use a narrow spectrum drug, not only do you have decrease in adverse side effects, decrease in the development of resistance to antibiotic therapy, but then you can also see that they are resistant to penicillinase, meaning they're not going to be broken down and they're going to exert a better effect, right? There are some times, however, where your true penicillin drugs are going to be sensitive to the penicillinase, right? And so these two right here may be drugs that we don't prescribe. If they're going to get broken down by that penicillinase, maybe we move up the spectrum, right? And we move to a more resistant narrow drug, which will be more effective. Now, what do you all need to know? You don't need to know this table, but you need to know that there are drugs in the penicillin group that are resistant to the enzyme that is created by bacteria. And then there are drugs, penicillin drugs that are more sensitive. And so knowing that is important because your patient, even though you're not prescribing the medication, your patient will come in. And in your drugs that are more sensitive to the penicillinase, you're going to see that they may not get better as soon as someone who's taking a penicillinase resistant drug. Does that make sense to you all? And so what it may make you do is refer that patient out to get a more resistant antibiotic, or penicillinase resistant antibiotic. I hope that makes sense. Now, y'all might be thinking like, what's acid stable and not acid stable? So a drug that is acid stable, what it means is as it passes through the GI tract, which we know can be acidic, it is not going to be broken down. And so there will be more of the drug available to be absorbed, right? Something that is not acid stable, so your ampicillin, right? And then your penicillin G, they're not acid stable. So what that means is as it passes through the GI tract, it will be broken down. And so there will be less of the drug available to be absorbed later on in the process. All right. So hopefully that all makes sense. Now we're going to another category of antibiotics known as the cephalosporins. The chemical structure is very similar to penicillin, and the mechanism of action is the same as well. So it's going to destroy the actual cell wall. That's how it's going to work. We have different generations of the cephalosporins, and I thought that was a key thing that I took away from kind of preparing for this particular lecture. Again, let's look at the spectrum first. So your first and second generation drugs, those are the drugs that were created first, right? Every drug is created first, and then we make things better over time. So as we look at this table, first through fifth generation, obviously they're getting better with time. Whether or not they work with gram-positive or gram-negative stained bacteria, whether or not they're more resistant or less resistant to the cephalosporin, that's an enzyme that's produced by bacteria, and then whether or not they're narrow spectrum or broad spectrum, right? So the top two, the first generation drugs, are narrow spectrum. Does that make sense? Narrow spectrum drugs. Your first generation drug was less resistant to the cephalosporinases, which means it was just broken down easily by that enzyme that was circulating, and so it wasn't as effective, right? As they moved down in generations, what they started to do was build a drug that was more resistant to the cephalosporinases. And so you'll see that this generations 2 through 5 are more resistant. What that means is they're not broken down by the enzyme, so there's more drug available to attach to the receptor and exert an effect, right? As you can see, as we move down generations, they became more broad spectrum, which can be good or bad, right? A broad spectrum drug will kill off everything. And we do need that option as we prescribe antibiotics. We do need the option of actually having some broad spectrum drugs, just in case we can't figure out what's causing the issue, right? Also, what you'll see as we move down in generation is the drugs became less selective to gram-positive, gram-negative. And that makes sense since they're broad spectrum drugs, they're going to destroy everything, right? Your generation 5 drug really hit the market with MRSA. So remember that there was a strain of MRSA that wasn't responsive to any type of antibiotic drug that we had. And so they developed a fifth generation cephalosporin drug, and that fifth generation drug was actually created to destroy staph. So if you have someone with a MRSA staph infection, most often they're on a fifth generation cephalosporin drug. Okay, last but not least, some things that you need to know about the cephalosporins that kind of maybe differ a little bit from your penicillins. It would be they're narrow to broad, which we saw on the other table. The other thing that you could see, adverse side effects, they're very, very similar to that of the penicillins. And so the only thing that would be different is maybe what they're used to treat. So in general, when we have maybe a soft tissue systemic infection, your cephalosporins would be a really good drug to prescribe for your patient. And in terms of excretion, all of these are really going to be excreted through the actual urine itself. Otherwise, your cephalosporins are very similar to your penicillins. Overall, what I would say, like if you're all like, Cosby, give me like the go-between, I would say that your generation 3 through 5 most often are preferred antibiotics when compared to the penicillins because of their resistance to the enzyme. So they just have a higher resistance to the enzyme. Next, we're going to be talking about your tetracyclines. They are also an antibiotic. Their mechanism of action is very similar to your cephalosporins and your penicillins in that they're going to inhibit protein synthesis, and so they kind of bind to the active transport mechanism, and they inhibit protein synthesis that way. They are bacterial static in nature, so not bactericidal like your penicillins, if that makes sense. And then in terms of their spectrum of activity, they're broad spectrum antibiotics. So there are no narrow options in the tetracycline group, right? Your tetracyclines, however, are most often going to be prescribed to kind of treat more, I'll say, catastrophic or more difficult to treat bacterial infections. So Rocky Mountain spotted fever would be an example, Lyme disease, pneumonia, and then last but not least, a very low grade tetracycline will be prescribed to youth who have acne vulgar. So it can be used to treat acne. It actually binds to the acne transport proteins and destroys them. And so you'll see a reduction in the amount of acne outbreaks in youth. So it has been a drug that has been used to actually treat acne in youth. It has a very long half-life. So what does that mean? Anyone? That you don't have to take it as much, right? This is like a once a day type drug. It's highly lipid soluble. So most often we don't want to give this to a pregnant woman, right? Because it's also going to cross over the blood-brain barrier pathway, and it might get delivered to the actual baby itself, right? Last thing to consider in youth in particular is that tetracyclines have, like if you look at the scientific literature, have been shown to kind of bind to calcium and destroy it. And so what we see in children in particular is inhibition of tooth growth, increased risk of stress fractures. So those are things to also consider as athletic trainers. Is if we have a patient who's taking this, let's say for acne, that's where we'll see it most often, at least in the high school setting, who starts to come into us with a lot of stress fractures, it may be that the tetracycline is inhibiting calcium growth, right? If it's inhibiting calcium, we know that it may also reduce their ability to heal from a stress fracture. So it might be a history question that you're actually going to ask for your patient as well. Okay, next are the macrolides. I'm not going to spend a whole bunch of time here. Your common drug for the macrolides is going to be your erythromycin. I'm sure we've all heard of that antibiotic drug. The mechanism of action is going to be just like the tetracyclines. It's going to inhibit protein synthesis, so not the actual cell wall, but protein synthesis. It's very bacterial static. So again, when we start talking about drugs that would be assisters of the immune system, this is another drug that's going to be an assister of the immune system, right? It's not going to destroy everything. The spectrum of activity is going to be both narrow and broad. It just depends on the type of drug that's going to be prescribed. But now we can start to see there's been an increase in the adverse side effects. So you get epigastric or stomach irritation, of course, the diarrhea, and then you can see vomiting associated with that. So what that tells us is that as we're starting to think about the therapeutic index, it's probably moving down a little bit, high for penicillins, and then probably in the middle somewhere. So we can see that there's an increase in the adverse side effects for this particular types of drug use. And so then what other things are we thinking about might we prescribe a microlide for? And most often like STDs. So treat infections of the gastrointestinal tract, but then also the genital. So like genital warts, for example. Maybe you have a patient who has some type of genital infection, right? Then it would be used to kind of treat that. The other thing that we see is patients who are allergic to the penicillin group. This is an alternative to that. It doesn't have that kind of beta-lactam ring, and so then they can take the macrolides. Most of the time, these are going to be excreted through urine, but also it could be excreted through bile. And then the one thing that I want to talk about is the absorption can be affected by food, and this will be the case for the tetracyclines as well. So example, if you eat food, it slows down the absorption of the drug. And so it has been recommended that you take these prior to eating so that it can be broken down and then absorbed by the target site. It can be impacted by food. So common classes are erythromycin, zithromycin, and clarithromycin. I think we've all heard of these. Again, for your penicillin, penicillin resistant patients, maybe, or patients who are allergic to penicillins, this would be a great alternative. It's just not going to destroy the cell wall. So it's not bactericidal, it's bacteriostatic. It's going to work indirectly, and that's okay. Next are your sulfa drugs. Your sulfonamides are called sulfa drugs in nature. They are systemic in nature, which if you're hearing me say systemic, then you know that they're broad spectrum drugs, right? So they're broad spectrum drugs. And so most broad spectrum drugs are going to be bacteriostatic in nature. Negative thing is they're going to destroy all the good and the bad. The sulfa drugs are interesting. So they're very much like your macrolides and your tetracycline drugs, in that they act indirectly. So they aren't directly destroying the cell wall. What they do is they inhibit one of the key enzymes that's needed for the synthesis of what's called tetrahydrofolic acid, or for short THFA, right? Tetrahydrofolic acid is extremely important because it fuels the mitosis process, so cell growth and then also division of the bacteria. In other words, if we inhibit the synthesis of tetrahydrofolic acid, then we see less division of the bacteria, which means there's less bacteria available in the system to kind of fight off, right? So that's an indirect way of destroying the bacteria. One of the things about the sulfonamides is that resistance can develop to them. In other words, a different type of enzyme could develop that could also fuel tetrahydrofolic acid, right? And then your bacteria develop different means to reduce the amount of sulfa drug entering into the body. So you can develop a resistance to the sulfonamides in different ways. The other thing that I want to say is I've had a few friends who have what are called sulfa allergies, and they didn't know it until they actually started taking the sulfonamide drug that was prescribed to them, and that it resulted in an anaphylactic condition where they were hospitalized and they developed like third-degree burns. That was like the body's protective mechanism. So my guess is therapeutic index is probably somewhere in the middle. There can be adverse side effects associated with that. One of the things that you'll see here is that they crystallize as they're being released if there's not enough water being consumed. And so they create almost like these crystals that come through the urinary tract, and that can be very, very, very painful. So you have to make sure with the sulfonamides that your patient is drinking more water than you would probably recommend for many of the other antibiotics that we've talked about thus far. The next type of drug are your aminoglycosides. The mechanism of injury is very similar to your macrolides and your tetracyclines in that they inhibit protein synthesis, and they are bactericidal in nature, but narrow. So again, they'll destroy everything. They'll destroy the specific bacteria. But again, that immune system is going to be very passive in this particular process. So the aminoglycosides are most often used intravenously. So we have maybe an acute systemic bacterial infection and we need to treat it right away. This is going to be the drug of choice. Most often, it's going to be, most of these are formed by two or more amino sugars connected by a glycoside linkage, hence the name aminoglycosides. That's kind of how they're formed together. And then the drugs in this course or in this class include the gentamicins, the tobramycins, the neomycins, etc. So again, these are going to be intravenous drugs. You'll have no interaction. But let's say we have a patient who walks into the clinic, has acute signs and symptoms, you're unsure of what to do, refer out to an urgent care. Most often, if they're going to treat with an antibiotic drug intravenously, it's going to be an aminoglycoside, right? So just keep that in mind. So reserved for hospital use. And so they're narrow, bactericidal, excreted via the urine. And that's all we have, right? They're in the inhibit protein synthesis category. Next are the fluoroquinolones. They're bactericidal and broad spectrum. So they're going to kill off everything good and bad. So the increased risk for adverse side effects with these particular groups of drugs is very, very, very high. But the great thing about this particular group is that they can penetrate many tissues. So if you're uncertain where the origin of the bacterial infection occurs, this would be a great type of drug to prescribe. They are effective orally, so you can see kind of their dosing here. They come in dosing packs for the particular patient, making it easy as we think about the patient's ability to take drugs and to be reliable in taking the drug. But again, be careful with foods, right? So we've talked about foods causing a decline in absorption. So we have to be very careful with antibiotic drugs and food therapy. Your adverse effects. I put this first for a reason so you can see it. Degradation of tendons, right? The biggest concern with the degradation of tendons is increase for ruptures, right? So oftentimes if we have a patient, I'm going to give you examples, patellar tendonitis, Achilles tendinopathies, this would not be the antibiotic drug that you would want your patient to take, right? Because it's going to slow down repair of tendon. It's going to cause degradation of tendons. And so they would be at a higher risk for the development of of ruptures. And so the other thing that we've seen over time with long-term use of the fluoroquinols is that they, what's the right word? They cause kind of lesions on weight-bearing bones, in particular the tibial femoral joint. In other words, what are you saying to me, Dr. Cosby? We've talked about osteochondral injuries. They kind of soften the bone and the patient develops osteochondral injury. So we have to be careful with long-term use of the fluoroquinols. And then the most common type of drug that we see prescribed in this particular category is going to be the Cipro. So types of topical antibiotic drugs: bacitracin, neomycin, pliomycin. Some of these are going to be over the counter and some of these are going to be prescription. Your top two are going to be prescription drugs. Your bottom one, the pliomycin, is going to be over the counter drug. All are bactericidal. So if you have some type of bacterial infection on the top of the skin, you're going to rub this topical antibiotic on, and it's going to destroy the bacteria in that area. We want them to be bactericidal, especially when the bacterial infection is actually on the skin. The big thing we need to figure out is if it's gram-positive or gram-negative, right? You can already see over-the-counter drug isn't going to work for gram-positive bacterial skin infection, right? So we're going to have to go to something that's more prescription in nature. Again, the only way to know that is to do what? You're going to scope it, you're going to put it under a microscope, and then you're going to figure out what type of gram it actually is. So routes of administration, I've alluded to this a little bit. You have your intravenous drugs, you have your topical drugs, which we just talked about, you have your intramuscular drugs, and then obviously we have our oral drugs, right? So we can think about this like, what type of infection do we actually have? That's the first question. Is it something on the skin? Then that's going to be topical. Are the signs and symptoms rapid enough to warrant referral to an urgent care and emergent care? Then intravenous is enough, right? Do we want to do an intramuscular injection and just do one? We do this a lot in patients who just maybe can't handle IVs or can't, for whatever reason, maybe a gag reflex, can't orally take an antibiotic. Very rare that we use intramuscular, but it can happen. And then we have oral, again, 7 to 10 days. They're not getting better by day 10. That means they're resistant to the antibiotic, right? So we want to refer them back out. Okay, that concludes the online lecture for just bacterial drugs. I know that's a lot to process. I'm not asking you to memorize the drugs, but I am asking you to really understand how each of the types of drugs work to reduce bacterial infection. Thank you for listening to this online lecture.